Diabetes is a global epidemic that is leading to a dramatic increase in one of the most debilitating diseases most have never heard of, but they soon will. It's called peripheral artery disease. The big issue is the misdiagnosis and underdiagnosis, leading to nearly 200,000 amputations performed annually due to P.A.D. More than 60% of those are in patients with diabetes. In our keynote presentation, Dr. Paul Michael with Palm Beach Heart Vascular will paint the picture of what the near future is going to look like if diabetes is not controlled and doctors continue to brush off P.A.D. as neuropathy. We've all heard that before. They've also talked about it being just part of aging or even brush it off as poor circulation. Dr. Paul Michael was recently recognized by the American Diabetes Association for his advanced skill set in diabetic foot care, as he was named Communications Director for the ADA's Foot Care Interest Group Leadership Team. Leadership teams consist of ADA professional members who have actually demonstrated notable achievements in and dedication toward specific areas of diabetes research and clinical practice. They're critical in helping the ADA develop strategies around research and care in these areas. Here is Dr. Paul Michael.
Thank you, Kim. I've essentially dedicated my entire career to this disease process, and it's for a very simple reason. Diabetes is the underlying causing factor in about 80% of everybody that's sitting in a hospital right now. Why is that? Well, we have to go back a little bit and understand the disease process. Now, I'm an interventional cardiologist by training, so an advanced plumber. But underneath those layers, I start off as an internal medicine doctor. And we can never forget that we are internists treating the whole patient, not just wounds or holes in the patient. But that's what diabetes leads to. It leads to holes in people's feet. And the issue with diabetes is that patients do not feel their pain. There was a famous book written by one of the most brilliant physicians that ever lived called The Gift of Pain. Without the gift of pain, we cannot feel what is going on with the body. So imagine a car, a motor vehicle that is left completely unchecked with no maintenance for 30 to 40 years. Imagine the rust accumulation. What would happen to the brakes? It would never last. It wouldn't even drive. So why do we allow this to happen to our bodies? Why does the healthcare system allow this to happen to the patients? And it all starts with education. And that's why my favorite population to speak with is directly with the patients. So let's go back and understand the history of diabetes. Diabetes, before the discovery in 1921 of insulin, was actually a disease of coma. So if you went to a hospital with diabetes, you were in the process of dying, and you were probably a child under 5 years old. If you somehow had diabetes later, you also ended up with coma. If anybody knows what the prescription for diabetes was, pre-insulin, I'll be very impressed. Feel free to email it to Kim, but I'm gonna go ahead and tell you, it was olive oil, bacon, butter, and protein. So what happens to the brain in coma? Well, the brain needs glucose, but guess what? The body does not need us to put glucose in our mouth. We have our own system for building sugar in the body, and that comes from fat and protein. I want you to throw out a word out of your vocabulary from today on. That word is diet. The word diet is confusing, and our goal with patients is to unconfuse the system. That way we can develop skills instead of pills and tools instead of rules, so that when we're out there fighting diseases on our own, we don't need a doctor to hold our hands. The goal of the physician is for you to never need them, unless you end up in a hospital or you need maintenance care. So educating people on what this disease really is. So the explosion of diabetes and the worse off global pandemic, even though we're in a time of social distancing and pandemic, but there is a monster of a pandemic out there called diabesity. And this pandemic we created and did to ourselves via the inclusion of significant and massive amounts of processed sugars in our diet. So what have we done to ourselves? We have changed the body's fuel system and made it lazy, dumber, and slower. Why is that? Well, the brain needs to feed itself off of generating glucose. So famous physicians were fighting to save patients, small amounts of patients from diabetes by discovering what the links in the body and what the causative factors and etiology of the pathology was. So when the pancreas does not produce insulin, the sugars rise. But when we ingest so much sugar that we make the pancreas go to sleep and the body becomes resistant to insulin, then the adipose tissue, and here's the new word for the day, ABCD, adipose-based chronic disease. So this explosion of adipose-based chronic diseases now began in the 1920s when diabetes became a disease of coma and now changed to a disease of gangrene. Well, why was that? We were allowing these patients to live long enough now by introducing insulin to actually live out the natural course of diabetes. And now the real monster showed its ugly head in the form of distal extremity gangrene, which leads to amputation. Then after that, we found out that patients with diabetes and no blood flow in their legs were really worse off. And that disease process is called critical limb ischemia. And the problem in the diabetics is they don't feel their feet. So when they develop wounds or ulcers from the diabetes, that led to amputations, which previously was required as a surgical management of an infection. So when the foot was infected, the leg was cut off. And now, thank God, we have technology to save limbs. So what is the underlying disease process that then develops? Well, that's called peripheral arterial disease. And that is blocked arteries anywhere in the body that leads to the organ not being able to work properly. If that's the brain, that's a stroke. If it's the heart, that's a heart attack. But when it's in the foot, nobody knows what it's called. Why not just call it what it is, a foot attack? If a foot is black and a patient walks into a hospital, then why are these patients not treated with the love and respect required to save their limb? It's because the system and the patients don't understand how to advocate for this pandemic. Because the importance of understanding the fact that diabetes leads to worsening of peripheral arterial disease. And peripheral arterial disease leads to critical limb ischemia, which is the gangrene. And gangrene, unfortunately, leads to death. And if I were to tell you the statistics, which I'm sure you're going to hear more of by our next speaker, who's probably the most famous person in the country on the topic, but the data is abysmal. These patients die. And worse off than that, the psychological and emotional effects of losing a limb is well known to be equivalent to losing a first-degree relative. Nobody wants to lose a limb. And you have no idea how many times I hear on a weekly basis, I would rather die than lose my leg. So that's why I take this disease so seriously, and which is why we created an amputation prevention center here in Palm Beach, Florida, which is synergistic with the community. So that this adipose-based chronic disease, which is a preventable pandemic, now has a mechanism to advocate, treat, and prevent this problem from ever happening. So let's talk about prevention. It doesn't make sense to wait for your car to break down to take it to a maintenance center. So that's where we need to screen patients at risk. So who's at risk for this disease process? Well, we can't change our parents. So 50% of the problem comes from genetics. But the other half is called modifiable risk factors. And all that mumbo jumbo means is things that we can change to live a better lifestyle. And lifestyle is the goal. It's not diet. It's not rules. It's tools to live by. That way we can actually live a life. Because who wants to have a boring life? There are many ways that we introduce mechanisms to empower patients to do this. Learning how to cook together in a fun way. So we have a diabetic cooking show. Gathering together in patient support groups, because that's fun. Cooking and sharing ideas over meals And I always like to joke around and say, I like to cook, I hate to bake, because cooking is fun. Baking is following rules, and baking is beautiful, but you have to follow it to the T for that souffle to come out perfect. But with cooking, you can experiment, you can have fun, and you can be creative. And I see medicine the same way. So empowering patients to learn how to eat so that they can meet their goals. So that's the first thing we talk about. It's not who are you and this is your goal, this is your weight, stop smoking. It's what do you want? What do you want out of your healthcare system to live a better life? And if they're diabetics and they're overweight, then we reach realistic goals. So we talk about how to get rid of the diabetes without talking about weight. So one of the interesting programs that we implement uses technology, because technology should work for us. We shouldn't work for it. Same thing with medicine. It should work for us, the healthcare system. So we've employed continuous glucose monitoring. We don't even advocate scales. That way, in real time, you're able to see what your oral intake and your lifestyle and your exercise levels are doing to your real-time glucose levels. So we put a little sensor right up by the triceps muscle in your shoulder. You can't even see it with clothes on. And now you have empowering data to take control of your body and your healthcare and your outcomes without even talking about guidelines or rules. And that's a tool. So now people are encouraged on searching out healthy lifestyle recipes. And we actually use high-end chefs to make it fun, because nobody wants to eat boring stuff. And what you end up seeing is patients come off an average of 2 oral diabetic medications and losing 30 pounds, and we don't even talk about weight. If your clothes size is getting smaller and you're feeling better and you're thinking faster and you're happier, then who needs the numbers? But obviously they're there because you have surrogate markers of success. And that's the next thing I want to talk about, is holding the healthcare system accountable for you, the patients. When you go to see a doctor, how do you know they're a good doctor? So what questions are you asking your physician who's there for you, but may not know what you want? Maybe you need a list of questions. Maybe you need to be empowered through education to know what to look out for to protect yourself. So what are the things that should be done for you, and what outcomes and what goals should you set with your doctor so that you can get something out of your healthcare to have better lifestyle? So if it's weight that you want to lose, set a goal. If it's medications you want to come off, set that goal. And if it's diseases you want to prevent, then talk about it. And the one we're talking about today is 𝗘𝗶𝗊𝗲𝗁, which has many different arms: heart failure, coronary artery disease, stroke, morbid obesity through bariatric metabolic medicine, amputation, the #1 cause of blindness, #1 cause of dialysis, and obviously the #1 cause of amputation in this country. Erectile dysfunction and sexual dysfunction in health is a huge topic that is ignored and not talked about in the doctor's office. And that's not right, because who wants a boring sex life? So at the end of the day, we have to be comfortable talking about these topics, because the person in front of us, the physicians, is a human being. And if we don't care about the whole person, then we're missing the mark as physicians. So under all of those diseases, what you can see in this country with a Western lifestyle is diabetes. And specifically our flavor of diabetes, which is turbo diabetes or diabetes on steroids in the West, is 𝗘𝗶𝗊𝗲𝗂𝗁. Did you know that the amount of sugar in soda products across the world is different depending on what country you go to? Now, why is that? Because they know how addictive sugar is. Sugar is more addictive than crack cocaine, people. When's the last time you saw somebody walk into an ER dying of crack cocaine? It happens, but half the people in the hospital are dying of diabetes. Who's talking about that? Who's talking about the fact that diabetes is fueling all of those diseases I talk about? But we're more interested in pills, not skills. We're more interested in putting people on machines to make them live longer. And maybe the quality of life is not that good living on a machine. Or maybe the person living on a machine could have had the tools to prevent that from ever happening in the first place. Who wants to drive 3 to 4 times a week, hooked up to a machine for 4 hours? Imagine the burden on the family. Imagine the burden on a family when somebody gets their leg cut off. How are they going to go to work? Who's going to cook? So what happens? Well, the loss leads to shock, and the shock leads to major denial, and denial leads to depression. So the psychological impact of diabetes feels much more than the $400 billion a year problem that diabetes is. Because if we take all things into account, it is one of the worst, if not the worst, inflammatory problem in the world. And that's why it's a pandemic. Just like the isolation and the depression of COVID is causing emotional inflammation, diabetes is the cardiovascular inflammatory driver of all of these chronic disease states. So what we have to start thinking of is preventing chronic diseases, and we have to hold the interventional community accountable for treating them. What do I mean? If you're opening blocked arteries, then something should change in that patient's life. If you're doing it for wounds or ulcers to prevent amputations, then we better hold that system accountable to prevent those amputations and to make sure that those patients don't get wounds or ulcers again. So we are not in the artery opening business. We are in the wound closing business and in the life-giving business, because saving limbs means saving lives.
I want you to go back over, because I'm really impressed with what you are doing to tackle this head on, this diabetes head on with the cooking show. And you were mentioning technology and using the sensors on the arms, on the bicep. What else are you doing? And is this something that's scalable across the US, maybe even around the world?
Absolutely. So the diabetes pandemic takes a village, and that's exactly what we've built. So if you look at the ABCD, the adipose-based chronic disease, the easiest place to start with is actually definitive therapy. So metabolic medicine, whether it's through coaching, through medicine, but what I'm specifically talking about is bariatric surgery. So if you have a good surgeon in your community, then the medical team needs to hook them in. Why is that? Well, if somebody has morbid obesity and diabetes, the chances of them reversing diabetes with lifestyle change alone when they already have ulcers is slim to none. These people can't walk. So we accelerate their workup to bariatric surgery to have surgical curative management of the diabetes. So get rid of the causing factor to begin with. Then what we need is a very strong diabetic foot care team, because once you've treated the disease, meaning get rid of the wound and open the arteries, you want to prevent this from ever happening again. So the diabetic foot care consists of people that can open arteries, people that can close wounds, and people that can manage the foot surgery. After that becomes a diabetology team, which does not have to be endocrinology. If it is, wonderful. But many people don't have access to endocrinologists. So internal medicine doctors who are trained in advanced diabetic care help coach the patients in bringing down their glucose levels and getting the medicines out of the home and getting healthy foods into the house and learning how to live.
And I think
the care coordination is important. So
yes.
We work together synergistically.
And I think that's a nice transition into our first question from one of our friends with P.A.D, Monique. What is your feeling on Ozempic? And I have a feeling I know the answer to that. You're trying to get people to transition off the meds and, you know, more into foods. But what is your feeling on Ozempic?
So the goal here is with peripheral neuropathy, what is causing the neuropathy in these patients? Well, number one is there is edema pressing on the tissue. So the nerves are being compressed. The sugar causes short circuiting of the nerves. What does that mean? Imagine lights flickering in your home on and off. The other extreme is the lights are just off. So you either don't feel your feet or they're going haywire, burning in the sheets at night. So relieving the neuropathy, reversible factors is getting rid of the edema, offloading the foot, controlling the sugars. So to treat neuropathy, you have to treat the underlying diseases. Everything else is Band-Aid management, unfortunately. And it's one of the most frustrating parts of medicine today.
There's a big difference between diabetic neuropathy and ischemic neuropathy.
Correct.
Can you discuss that? Because I think that there's a little bit, even with primary care physicians, I think there's a misunderstanding. And it's really tough to test for until you go the invasive route.
Well, the issue is that when patients are presenting with advanced peripheral arterial disease, they're essentially presenting with cancer of the foot. So they're not feeling the foot from the peripheral arterial disease because of the neuropathy. So when patients can't feel the foot, it's easy to say this is a neuropathy. Well, they're not wrong, but the distal neuropathy is only part of the constellation. The lack of blood flow is what's also contributing. So you have to look at a complete workup, which is why it takes a team. But it doesn't take much. Take the shoes off, take the socks off, measure pulses, and measure for neuropathy. So that's not that hard. And you'll be surprised how many patients have tiny little wounds in their feet. And it just takes a little bit more to set it off. Some pressure, the wrong shoes, which is why foot care is so essential and overlooked.
And Bob's question, does revascularization alleviate the diabetic neuropathy pain to any degree, and does it generate nerve regrowth?
So actually, Rutherford category 4 peripheral arterial disease is known as rest pain. This is miserable, excruciating process. So absolutely, it's one of the indications to urgently open the arteries, which is called revascularization. So you're beyond cramping. The foot is so cold and ischemic, it's intolerable pain. Patients can't even walk to the mailbox. So opening the arteries needs to be done, but it needs to be done carefully also by a well-trained team, because when you're opening arteries quickly that have been blocked for a very long time, it can actually worsen temporarily some of the neuropathy symptoms, because now these nerves are coming back online and they're hot essentially. But yes, with a trained team, these arteries need to be open, can be open, and save the patient's limb and their life.
And another question, we're heading into winter, and no matter what, that neuropathy pain is worse during the winter months. Any relief when it rains?
Relief of neuropathy when it rains. Well, I think since we're talking about peripheral arterial disease, we have to establish a couple of things. If you have pulses that are palpable and you have a neuropathy, then that is probably not peripheral arterial disease. So physical maneuvers and keeping the feet warm, but be careful, because if diabetics are improperly treated in their feet, that can lead to wounds independent of having open arteries. What does that mean? Even if you have open arteries, you still develop ulcers from the diabetes. Keep that in mind. So foot protection, foot inspection is imperative. Make sure that a podiatrist or your doctor or your spouse is checking your feet and that you are not cutting your own toes if you're at risk. That's one of the worst risk factors to set up a self-induced wound that can lead to an amputation.
And one last question, and this is a good one to finish with. Marcy said you mentioned a few critical questions to ask the doctor, but she wants to know if you could just summarize, maybe 4 or 5 critical questions that you shouldn't leave. If you have diabetes, you should not leave the office without asking.
Okay, so what is a diabetic foot? A diabetic foot, I'm going to explain this to you, and please don't forget this and write it down, and we'll email it to you back. It is a foot that you cannot feel. It is then a foot that walks improperly, and it's a foot that then gets a wound. So you can't feel, you can't walk, you can't heal. That's what leads to the amputation. Your doctor will never know unless you take your socks off and show them, unless you're screened. So if you have diabetes, you are at risk for amputation, dialysis, and blindness. That should be taught at elementary school at the cafeteria level. But we're playing catch up here, okay? Peripheral arterial disease leads to, if untreated and unchecked, cancer of the feet in the form of critical limb ischemia. This whole constellation is a preventable pandemic by controlling one thing: sugar intake. So together, let's attack diabetes.